One of the common skin conditions that we see in our skin clinic is that of eczema problems. Eczema basically refers to just an itchy rash. It can happen in any age group, but predominantly it starts off in the childhood age group, and for about 40% of the patients, they do progress to adulthood. But 20% of the cases for eczema actually do occur in the adult age group. So it's not exclusively in children itself. It can happen in both age groups. Eczema, there are a variety of conditions. It's just an umbrella term, okay, to refer to a itchy skin rash. Some of the eczema problems that we have seen include things like discoid eczema. We have seen things like xerotic eczema. But the most common is still what we call atopic dermatitis. In atopic dermatitis, it usually presents with an itchy rash, and the rashes by itself can be intermittent in nature. It can get better and then it can get worse again. So there's this fluctuating mode. The thing is that sometimes people think that it's completely resolved, okay? But if you look carefully enough, there is still some residual rashes, and that's one of the reasons why sometimes we do encounter failure, because they don't use the treatment sufficiently enough. To them, it's once they think that the itch is better or they don't see the rash, they stop, and therefore the slightest trigger, it will come up again. For eczema itself, one of the ways in which we diagnose is basically based on the history as well as the clinical findings. History that we are looking for includes the presence of a persistent rash, the fact that the condition tends to recur, and the presence of a past history as well as a family history of sensitive conditions like allergic rhinitis, allergic conjunctivitis, or even history of asthma. For the clinical findings, we look mainly at the distribution of the rashes. For most cases, we tend to see it more in the flexural regions. Flexural regions refers to the neck area, the elbows, and also behind the knees. We also look for the presence of dryness of the skin. Some other findings like things like hyperlinearity of the palms, that means you see multiple lines on the palms, and we also look for what we call follicular accentuation. That means the pores are very prominent, or you have this plugging of the pores. We don't usually need to do a skin biopsy. It's essentially a clinical diagnosis, and but if the condition if the patient is being treated and is complying to the treatment but doesn't seem to respond to the treatment, only in situations like that we do a biopsy to make sure that we're not missing other mimicals of the conditions. The treatment per se essentially would be the use of creams. Because sometimes, as I mentioned earlier, this condition can progress to adulthood, and it's therefore quite a lifetime kind of a treatment requirement. So if we can avoid oral medication, we do avoid oral medication. The most important thing about management is to empower the individual, to let them know what is this condition, what are the potential triggers, and what are the steps they need to do to improve the condition, to bring under control. So sometimes along the way, we do things like a patch test or skin prick test to determine whether are there potential triggers in the environment that can actually aggravate the condition. Important thing is that once we identify those conditions, avoidance is important so as to minimize the flare-up from these triggers. We do this thing called proactive treatment, whereby even when they are well, we do encourage them to apply not only moisturizers but also to apply topical steroids or what we call steroid sparing agents so as to minimize the flare-up. And we do educate them the need to use steroids, okay, whenever there's a flare-up, to bring down the conditions quickly so that the condition do not fester long enough that will make it more resistant to treatment. There are certain cases whereby they do get infected. We call this infected eczema. In cases like that, treatment do require the use of antibiotics. Sometimes we do a wound swab just to make sure that the organism that has infected the wound, is amenable to the antibiotics we are giving. But by and large, most of the time they would respond to the standard antibiotics such as augmentin or cephalexin. On top of that, we do give topical steroids as well as some antiseptic wash to help to minimize the contamination and the bacterial load in the area of involvement. It's important to treat the infection, otherwise the condition will not get better, because it has been shown that if it is infected, the organism present, mainly the Staph aureus, can actually result in a bit of resistance to the steroids that you are applying to the wound. At the same time, there's also the production of toxins which can also stimulate the immune system, and therefore you can actually get an aggravation of the rash, also an extension of the rash beyond the original site of involvement. Gentle cleanses are also very important. The main thing is that do not use too harsh kind of cleansers. The problem with Chinese is that we all like to, or Asians is that we like to get this dry sensation because we equate dryness of the skin with cleanliness. But that is bad for people with sensitive skin. The more dry the skin, the more likely you're going to get a flare-up of the skin condition. So when you use a gentle cleanser, okay, what happens is that you give a bit more lubrication to the skin is a bit more flexible, less likely for the cracking, less likely for fissuring to happen, and therefore less likely to trigger a flare-up. With regards to food allergies itself, what I would usually advise my patient is that if we talk about food allergies, most of the time we are actually dealing more with hives, or what we call as urticaria. The patient will usually present with blotchy red patches that last for a few hours and resolve, or they may get a bit of facial swelling or lip swelling. Very few, I would say, in our practice actually have food allergy triggering an eczema problem, but more likely it will be a food allergy triggering a hive reaction, and when the patient is scratching, it causes damage to the skin, and the damaged skin therefore may trigger an aggravation of the eczema problem. So that might be more the likely scenario. It's very important to emphasize that a lot of times it's not food allergy, because a lot of the patients that we see are usually in the younger age group, and they are in the phase of growing. They need the necessary nutrients for physical development, for mental development. And when you tell them it's a food allergy, or when the parents think it's a food allergy, there's a lot of restriction on their diet, and this actually can affect their overall well-being, their overall growth. And that's not what we want. I've seen cases whereby they keep thinking there's a seafood allergy, there's chicken allergy, there's egg allergy, and the fact that the child is not even eating at all, and the child comes very scrawny and undernourished, and that is not good for the child. So important thing is always, during part of the consultation, is to empower the patient, to let them understand what this condition is all about, what are the potential triggers, and sometimes that's where the skin prick test or the patch test comes in, is to prove or disprove a point. And then for them to get that assurance to know what can be done and what should not be done. And then hopefully together, hand in hand, we can bring about a better control of the condition.